you can begin your presentation. Thank you.
Thanks, Steve. Thank you very much. Thanks for the opportunity. My name is Ruba Haddad. I'm a cardiologist, heart failure specialist. I work at Macquarie University, and I'm very interested in cardio-oncology. I have been involved in cardio-oncology cases. We don't have a formal cardio-oncology service yet. I'm looking forward in the near future, probably sometime early next year, to have a formal clinic here in the area. I would like to share this. I'd like to share this case with you that I was involved in the management last year, and I thought it's a very interesting cardio-oncology case. So we'll start with. So this is a 78-year-old female who presented with a 3 months history of nausea, low appetite, occasional vomiting, and feeling tired and fatigued. She has extensive medical background of cancer. So she is known to have lung cancer, non-small cell lung cancer, and she was on erlotinib. She also had lymphoma, and she was treated for that, but unfortunately relapsed in October 2018, and she received bendamustine and rituximab. And she also known to have what was thought to be low-grade renal cell cancer that was causing compression in her renal pelvis and causing hydronephrosis. She was booked to have left nephrectomy in August 2019. She also has a benign salivary gland tumor, and she had regular surveillance for that. She also had multiple lesions in her spleen and was not really clear if that was metastasis from her lung or from her lymphoma. She had a well-controlled hypertension and type 2 diabetes, and she was osteoporotic. Her baseline creatinine was normal with a normal GFR. She has a strong family history for non-small cell lung cancer, and they're all non-smokers. So she had a brother who was diagnosed with stage 1 EGFR mutant non-small cell lung cancer in his late 70s. He had surgery and now he's doing well. He's in his 80s. She also had a nephew who was diagnosed with non-small cell lung cancer at the age of 52. She has 2 daughters and 1 son, and one of her daughters has T-cell lymphoma. So these were the medications that she was on. Her initial presentation was to one of the major public hospital here in Sydney, and she was initially managed there. Then she was transferred to our facility. This is her ECG on presentation. So she had no shortness of breath, no chest pain, no exertional unusual symptoms besides her baseline. So what do you think of the ECG? Any comments?
Yeah, that's massively abnormal. What is entecavir? That's one of her medicines.
I think it's, yeah, I thought these are, she was, because of lymphoma, she was on antiviral.
Yeah, so is that a preventive medicine, or is that?
I think so, as a prophylaxis.
Okay.
I did check her list of medications, and they don't seem on the credible meds to be associated with, you know, this ECG abnormality. So it's under the brand name. It's an antiviral.
Yeah. Okay. Yeah, you can go back to the EKG. You skipped over your picture of Sydney. That was a beautiful picture.
Yes. I know Steve said in the near future, after COVID-19, hopefully there may be some potential cardio-oncology conferences here in Sydney.
Yeah, I mean, That's such an iconic picture that, you know, I've never been there, but it certainly looks beautiful.
This is the Opera House, the famous Opera House.
Yeah, so your EKG has really profound QT prolongation, but also T wave inversions that are quite impressive. But it's so diffuse that I would think that's a metabolic problem, either medication or a metabolic problem.
Yeah, so for just to add for the Entecavir, she did have some one of her like IgG hepatitis B in the past positive, and I think that she was on that Entecavir for that, given that she has lymphoma and probably she was immunosuppressed, compromised. Yeah, so there is very deep T-wave inversion. It's very abnormal ECG, and there is also very marked QT prolongation. So what other causes do you think like differential here? Any comments?
Cardiomyopathy, previous cardiomyopathy, or for example, central brain, ICH, brain problems.
Yeah, so we went ahead and did some investigation. So this is her ECG 1 hour later. And remember, that was not really an acute presentation. So this is the previous ECG from March 2019. And obviously, this is ECG is abnormal and probably something happened after March. So this is not her resting or a baseline ECG. So differential diagnosis, as mentioned, and we went ahead and did further investigations. In fact, she had some of those done in the primary hospital. So these are her labs. Electrolytes are normal. Kidney function is normal. Calcium, magnesium was normal. Phosphate was normal. And her troponin was just slightly above the cutoff of the lab, was 16, hers was 19. So this is her echo. Again, that was a copy from the initial echo that she had. She came on the 24th of July, and that was her echo from the 25th. So any comments?
I can't see it really well, but you know, it looks like her apex is particularly thick, and that would make sense to some degree on the EKG findings. I mean, if you have an apical hypertrophy, then you can get those deep T-wave inversions. But it's kind of interesting that the second EKG that you showed, if you could go back to that one, there's an interesting beat that probably deserves a little attention. So if you look at the third beat, and
this one?
Yeah, and you look at the beat immediately preceding it, it's narrow and the T-wave changes are less, and probably there was a PAC that led to that beat. And it's really curious that the QT interval was basically normal on that beat. And then you look at the rest of the beats, you know, the QT is markedly prolonged. So that probably indicates that there's like an accessory pathway, I would think.
Accessory pathway giving the prolongation of her QT.
Yeah. Yeah, because how else do you explain that narrow beat? That second beat.
Yeah, this is interesting. Yeah, it is less. The QT there is less than the QT here.
Excuse me. I think in the second beat we have a normal QT because we have pause after that, and maybe we can't judge the proper QT in proper QT duration. As you know, we have a pause after that, and so our duration is different from the other beats.
Right, but the QT interval in part is determined by the preceding beat. And
Yes.
so I think that it's hard to explain why that beat, which is narrow, and the QRS duration is narrow, and the QT interval is narrow, and that beat actually came in a little early. It's hard to explain why that would happen unless, you know, it's not a metabolic effect. If you had a diffuse metabolic effect, you would have QT prolongation every beat, regardless of whether it was a PAC or not. Now, in this case, I mean, it's really curious why that beat is so much different. And that's why I say it may indicate an accessory pathway, because on that particular beat, it didn't go through the accessory pathway.
Yes.
Yeah, but I think
Interesting.
the interval is set by the preceding RR interval, so it's got to be shorter. I see that all the time. And treatment for torsade is actually to increase the heart rate just to get the QT shorter.
I know, but how would you have such a dramatic beat-to-beat variation? That is hard to explain.
Correct. I mean,
Yes,
this
correct.
looks like a drug problem to me, honestly.
Okay. Interesting. I did see this. I did see this beat, and I thought, okay, yeah, probably this is ectopic, but I didn't go into that details that you've gone through. Interesting. Okay, so we did further investigations. So her electrolytes is normal. They were normal. Her echo, although that gave the impression that probably the apex is thick, but actually was not really thick. On further investigations, as one of you mentioned about intracranial pathology, she had a CT brain non-contrast, and there was no intracranial pathology. She had it with non-contrast and contrast, and no metastasis. CTCA, she had only minor coronary artery disease, minimal, less than 25%, and her coronary calcium score was only 58. So we went on to cardiac MRI, and she had normal LV ejection fraction and right ventricular fraction, and the wall thickness was normal. And we had this MRI reviewed by two senior cardiologists, and they agreed that was normal, and there was no myocardial lit enhancements. And was normal in terms of no LV wall abnormality or thickness. So we mentioned like cardiomyopathy, and with these deep T-wave inversions that are involving most of the leads, we thought like yes, differential could be a stress cardiomyopathy in this patient. And we know cancer patients have lots of factors that predispose them to stress cardiomyopathy, including the cancer itself, the physical stress, emotional stress, and also the therapy itself.
Yeah, but the only problem with that general theory is that she doesn't have a cardiomyopathy. There's no cardiomyopathy.
Yes, she doesn't. Yeah, true. She doesn't on echo or MRI. But I'll just go through the stress cardiomyopathy in terms of presentation and ECG changes. So with the stress cardiomyopathy, we know it does have different names. It took its name from the apical ballooning from the Japanese octopus trap. And it is usually associated with LV, transient LV dysfunction that goes back to normal in a non-obstructive coronary artery disease, coronary arteries, and also when there's no pheochromocytoma. So there are different theories, and one of the theories is the catecholamine hypothesis in terms of pathogenesis. So it's usually a trigger, either physical or emotional stress, that causes catecholamine-induced microvascular spasm or a dysfunction, and or could directly affect the myocytes, causing a transient myocardial stunning and also ECG changes. So presentation usually, although they come with, majority come with a typical chest pain, similar to STEMI, right? They can also still come with, they can present with dyspnea, syncope, heart failure, or even cardiogenic shock. ECG, most common is ST elevation, but they can still present with T-wave inversion, ST depression, a bundle block, any abnormal non-specific T-wave changes. In stress cardiomyopathy, the axial ballooning, the most common type, there is temporal evolution of the ECG. So once there is resolution of the ST segment elevation, there is progressive T-wave inversion and QT prolongation that take place over days. And this by itself, it will take some time to resolve. It will take days to weeks and sometimes 2 months. And this is because of the myocardial edema there, which we did not pick on cardiac MRI in this case. Although the LV may normalize in about ejection fraction, may go back to normal in a mean of 7 days. So we were thinking, like, are we dealing with a stress cardiomyopathy that probably presented somewhere here rather than here? So the negative T wave of Takotsubo, they're usually very deep and wide, diffuse, and affect most of the leads. And if you look at V1 and find that there is no negative T in V1, but there is a positive T wave in AVR, that has a 95% sensitivity and 97% specificity. And if you go back to the patient's ECG, you will find the characteristic deep T-wave inversion, most of the leads, and they are positive in AVR and the T-wave, and also the T-wave is not negative in V1.
THARDRI.
Any comments so far? Do you agree?
I'm still waiting to see what you tell us. So
I'd like to hear your comments though.
yeah, well, I think it's hard for me to invoke a Takotsubo cardiomyopathy when there's no cardiomyopathy. So
yeah, but she did not present in the so basically the presentation was not really acute. So she presented somewhere here.
yeah, but
So
she had EKG changes.
she does. And the
Right.
ECG changes, they lag behind. They can lag behind for a while.
Yeah, I don't know. I think that's a stretch.
Excuse me, how about Wallenstein? For example, rule out ischemic changes.
Yeah, her CT, the Willen syndrome, you mean the Liftman? The
Yes.
Willen syndrome, that coronary, the CT was okay.
Okay,
CT
yes,
coronary was okay.
Thanks.
Yeah, so I'm reserving comment until you give us more information, because right now my best theory would be that this is an aberrant pathway.
Okay. But I never come across an accessory pathway causing that prolonged QT and very widespread abnormal T-wave inversion like this.
No, but I've seen lots of strange things.
Okay, interesting. So these cases, in fact, the Takotsubo cardiomyopathy and a very abnormal, prolonged QT like this patient. She had her QT interval stretched more than 600 milliseconds. The importance of that is if they too present in this period, especially the cancer patient, this will provide a risk for torsade and ventricular arrhythmia.
So I wasn't able to unmute a second ago, but I would just echo the comments that it's certainly plausible that you're saying that maybe they're coming in late after they read resolution of the cardiomyopathy. But I just haven't seen it yet, and I don't think Dan's seen that yet. But it's an interesting thought. Certainly, we do see these negative T-wave inversions a lot in the metabolic derangement, and they often have a normal workup. Sometimes they have low potassium or something else that's going on, but often the electrolytes are normal. It doesn't really get explained, and we don't necessarily have a definitive finding. And so we're left with this kind of academic discussion of whether or not, something else was going on, and we weren't able to pinpoint it, unfortunately. This person certainly has had a fairly complete workup.
Yeah, she did, and her electrolytes presentation was normal.
Yeah, and I was just saying that, often when we see this, when we're seeing patients in the hospital going through their cancer treatment, we'll have a pretty normal cardiac evaluation like you did in normal electrolytes, but there's not this question of whether they had a preceding cardiomyopathy that you're having. In any case, those patients, we usually are able to describe it to more metabolic or drug-related reactions than a Takotsubo. That's just much harder to prove to say that they had one and it resolved. But it's an interesting thought.
And how long does it take for the ECG to resolve? How long, like with your experience when it's metabolic causes? How long does it take for the ECG to go back?
Or we think it's drug-related, then it would normally resolve after the acute time period, but we wouldn't necessarily continue to do serial EKGs to see if it's resolved, so that's harder to say.
Okay, yeah. Okay, I was thinking, could this be silent Takotsubo? Because we know that silent Takotsubo occur in ICU patients, as international studies showed, and also the study from Sydney late last year, where they showed that 3.5% of ICU patients who were sick and needing no adrenaline, they had apical ballooning and typical Takotsubo that was transient. That did not seem to affect their ICU, the length of stay in hospital or ICU, and there were no deaths there. So this is her ECG on the 28th. There are no ectopics there, but the QT, there is still like marked T-wave inversion and QT prolongation.
Yeah, I mean, the PR interval's short.
It is short, yeah.
And so that's, again, another reason why I'm sticking with my aberrant pathway.
Yeah, but there's no delta. It's not like the typical, yeah. I know what you mean, but it is short, shortish.
Although certainly the T waves have changed, like there's some progression of whatever's going on. As a side note, obviously this person's not having Welland's T waves with the proximal LAD occlusion, but these appear more Wellanoid to the question earlier. They're more symmetric. The previous ones really weren't Wellanoid in that they weren't symmetric, and they're very atypical pairing. Normally with Wellanoid, though, we can even see deeper T waves in this. They can be very profound.
Ruba, there's a question in the chat box just asking, what is the race of the patient? And
she's Asian. Yeah, okay. So she is, I forgot to mention this in the family history. So she is she's an Asian from Papua New Guinea. So her parents migrated from China sometime to Papua New Guinea, and she migrated here in 1965. So she's Asian background.
Thank you.
Is there any changes in her medications at all? And also, I missed the very beginning, but was there some kind of event that caused you to get an electrocardiogram?
No, there wasn't. Like she was, so basically these were her medication for a while. And when she came, they changed verapamil to bisoprolol, basically when they saw the ECG. But prior to that, there was no other changes in her medication, like not that I'm aware of.
And how long later was this EKG?
That was in March, the one I showed you earlier. So the one I showed you earlier, that was March. Then this one, that was March 2019. Sorry,
no,
no, this was no. Sorry, no, this is a mistake. Not my, this is the March one looks like this, but I must have written the wrong one there. But yeah.
The QRS.
I was just wondering how long later was this second EKG from the presenting EKG?
The second ECG was on the 20. So that was the first one on the 24th. And 28th was the second one. The 24th again, and then this is the 28th. So that was 3 days later.
Because I really like your discussion, and I like the idea of this. Did we miss a Takotsubo? Because I think those are largely academic questions because we don't always get an answer, and you obviously did as good of a workup as you possibly could have. But it is interesting that these EKG changes seem to be improving. Obviously, they're still present to some extent, but this is better than the previous EKG after stopping the calcium channel blocker, which might have had.
Hey, this is Courtney Campbell. I've got a quick question. Did she have any neurologic changes, or I might have missed it at the beginning, but any kind of workup for a stroke or small changes?
Yeah, so she didn't have any neurological symptoms, and we thought about like intracranial pathology. She had CT imaging with contrast and without, and that was normal.
But no MRI?
No, she didn't have brain MRI, no. Is there any certain conditions you're thinking of that was not picked up on CT?
Well, just the ECG changes you can see with Takotsubo are thought to be related to the catecholamine surge, and certain strokes in certain locations, like I think it's the insular cortex, can have similar effects and have things like T-wave inversions are very frequently seen in after strokes. So depending upon the location, so sometimes those can be pretty similar.
Yeah, there was no neurological symptoms at all, and brain, the CT brain was normal.
Excuse me.
Yeah.
So your diagnosis is by rule outing the other differential diagnosis, yes?
Yes, yeah, I was thinking of the very widespread T-wave that she had, and the positive V1, positive AVR T-wave, and she was anxious in terms of, there was like the, by history, there was like the anxiety of upcoming surgery. She's a cancer patient. There was anxiety about her, very much anxiety. The daughter said, when her husband goes to shopping, she was anxious, and she wasn't before, in terms of she will ask her brother, the one in his 80s, to come and sit with her until her husband come back. And we thought, okay, these T-wave changes, we did all the other investigations. So is this Takotsubo? And we do see this in Takotsubo patients, these like similar changes, ECG.
Yes, of course.
Yeah, I mean, I think I could accept that these EKG changes might represent stress cardiomyopathy, but I would have expected to see a cardiomyopathy. So in the absence of a cardiomyopathy, it's hard to blame those EKG changes on that.
Yeah. Yeah, I understand. Yeah, even if that was like, you know, in the non-acute phase of her presentation of the event, I mean, because she didn't have any, like any acute cardiac presentation.
Yeah, I mean, I think it's essentially an academic question, and I think it's a good one to have, and it's an interesting debate. But since we'll never know what her heart function was the week prior. We'll never be able to say. Certainly, when we normally see Takotsubo in my clinical practice, we would see some level of cardiac dysfunction when we see EKGs. That's only because you'll never know what happened beforehand. And more likely when we see these EKG changes, we're thinking drug or metabolic derangements. But we don't necessarily always prove that either. So in the end, it's something that is a somewhat academic question. But I think it's interesting, the discussion and the possibilities, and to think about the future.
You know, if I may comment, usually you make a diagnosis of Takotsubo because the person has had some kind of event, and usually it's something related to heart failure or maybe chest pain. And that's when you get them hospitalized, and then you see them. If she didn't have that, then she certainly could have had and we know the LV function dysfunction may be transient in some cases, although this is a rather dramatic T-wave changes. I don't think it's outside the realm of possibility that you just missed it because she didn't have those symptoms or she didn't recognize them. And then for some reason you got an electrocardiogram unrelated to anything, and here it is. You know, that's a possibility based on how patients normally present. And she just didn't have those presenting symptoms, and there is a delay.
Yeah, to the, I guess, a parallel point though, you presented evidence that patients in the ICU can have silent Takotsubo. And as Dr. Krohn mentioned, usually Takotsubo is related to an event. So the fact that they're in ICU makes it more likely that they'd have Takotsubo. It's harder to know what the incidence would be of a silent Takotsubo without any symptoms or events to go along with it.
Yeah, true. Yeah, so on the 3rd of August, which is about like 10 days after she was admitted, she did have shortness of breath and she had shortness of breath and she had pneumonia, expected temperature. Pro-BNP was slightly up, and she was treated. And that was her ECG on the 9th of August, just a progress ECG. And we can see that these changes are improving. Less deep T-wave inversion than the 24th. And the QT, of course, he is less than before. So on the 18th, she got worse. She spiked the temperature and she had E. coli in her urine. She also had hematuria and we started antibiotics. And that was her ECG on the 18th. Then in the evening, she had a blue code for 8 episodes of this.
And so that fortunately looks like artifact. Oh, actually, never mind. I'm sorry. I was thinking the lead on the left is the same lead on each one, but that's a time lead.
Oh, this is the O2 there, and this is the this is her lead. So this is the ECG and there.
Oh, that's real.
Yeah, that looks real. Sorry, my initial comment was just comparing on the left, the top, the middle, and the bottom, but that's a timeline.
And all these are like different. Yeah, so she had 8 of those. That was the monitor, printout of the monitor, and that was the screenshot, and that was a printout of the monitor.
But she doesn't follow any rules at all.
No, when the QT get better, she was sick and septic, and she had, unfortunately, she had these torsades. So this is her ECG from the 18th. She went into a transient right bundle branch broke just before she had, on the day she had these torsades. So she was very unwell. She was hypotensive, pro-BNP very high, 32,000. She continued to have some hematuria, and she grew E. coli in urine and blood that was only sensitive to meropenem. So we kind of discussed, that night, the outcome with the family, and we thought, okay, we sent her to ICU. She had IV magnesium. She didn't need any, trop, but we diuresed her. And next day she got better. She turned the corner, but she was on erlotinib all that period. She was on her Tarceva, and that was not stopped. So she survived the septic event, and we thought, okay, with Tarceva, what do you do? Do you want to continue or put it on hold? What's your experience with Tarceva and QT prolongation? Hello.
I haven't
seen. I can't say that I've seen that, but she was on a number of unusual medicines, and so you don't know if those conspired to form the perfect storm. So that she's on 2 viral medicines and Tarceva, and then whatever other medicine she's on. So you don't know if it's the combination of those drugs that are causing those changes. I think anytime somebody has QT prolongation and you don't know the cause, you should probably eliminate all unnecessary medicines. And whether Tarceva is absolutely necessary or unnecessary, I don't know. I don't know about that.
Mm-hmm. I'd agree with Dan's comments for sure. And then, I can't remember whether you said she was on diltiazem or verapamil, but that was stopped, and we certainly would try to avoid that when possible due to drug-drug interactions, except in particular cases. And so, and her QT seemed to get better after that was stopped. I don't know if other changes were made. But certainly, it's always important to know that websites like Credible Meds are based on evidence to date. And with newer cancer therapies, we're always learning these things. And so we should always keep in mind that with new therapies, things are possible, even if we don't find them there. And eliminating other unnecessary drugs so that we can focus on the cancer therapy is always a priority when we're not sure what's causing it. It's a good case to highlight that the pro-BNP can become significantly elevated in the setting of sepsis, which happened in this lady here that she got better.
Yeah, and in fact, the oncologist said like they didn't come across problems with Tarceva and QT, but there was a study that looked at the tyrosine kinase inhibitor, and they found that erlotinib can be associated with increased QTC. So because she kind of got better, and we were talking about NFR the night before, not for rhesus, and she improved next day, we thought, okay, we're going to put erlotinib on hold and give her pantoprazole, because she had this persistent nausea. And during her stay in hospital, we got the GI team to see her and the ENT, because she also had this persistent dry cough. So just to remember, with PPI, proton pump inhibitor, and erlotinib, they're contraindicated to be given together because PPI result in significant decrease in GI absorption and significant decrease in plasma concentration of erlotinib. But we talked to the oncologist, and she agreed we can put it on hold for a few weeks and see how she goes. And her nausea significantly improved. This is just like the guideline. discontinuing any medication that causes a QTc of more than 500 or increase of 60 milliseconds from baseline. But we didn't have any medication to kind of, point the finger at that stage. So we stopped her erlotinib and we gave her pantoprazole, and she improved significantly in terms of nausea, and she started, even her eating was better. So just a quick discussion about like the QTc, that it's very important when measured always to use, for comparative reasons, to use the same method. We use buzzets. It's also important to use the right leads, lead 2 or lead 5, but not any other leads, because lead 2 really showed the very clear termination of the T wave from the U wave. And including the U wave can overestimate and inflate the QTc by 80 to 200 milliseconds. So remember that the end of the T wave is not really the end of the depolarization of the myocardial depolarization, it's the end of the U wave. Since all measurements and studies use the QT, so it's important to use the QT interval, and most of the time the U wave is filtered out of the by the ECG machine anyway. So this is her ECG on the 19th of August. So Dan, what do you think of the PR?
It's still a little short, and because you've shown so many EKGs with varying QT prolongation, I mean, this person could have a genetic susceptibility to that, and then the some combination of medications resulted in significant QT prolongation. Yeah, I don't know. This is a tough case. I don't have a good underlying theory for all of it.
Yeah. Yeah, and this QT is better than the QT she presented with, but still stretched, right? It's still prolonged, and the PR is not as short as the first ECG.
No, but I think that especially in years past, we don't do this kind of evaluation in the current day, but definitely back in the late 90s, early 2000s. When you had somebody that was, they had a WPW in some form on their EKG, you would exercise them to see if it went away, because increasing the heart rate and increasing the repolarization may change the QRS formation. And so, that was considered a low risk WPW, because it would go away with exercise. And so I think that, nobody does that anymore. I mean, now everybody just gets ablated. So you don't really see that anymore. But I wonder whether this is part of the explanation in this patient. But like I said, it's not apparent to me that, we have an underlying explanation for all of it.
Yeah.
Excuse me.
Yeah.
We have a low magnesium level, as you show in the lab data. Can we think about the reason, one reason for torsade de pointe or not?
Oh, you mean it was not in torsade and ventricular arrhythmia? We like it at higher than the lab level, right? But that was within the cutoff. She didn't have like a ventricular arrhythmia first when she presented, but that was within the normal lab limits.
Normal, yes.
Yeah, that was within the normal range. But in the setting, of course, of torsade, we need it to be higher.
Yes, of course. I think that when we have cardiomyopathy, we should increase the level of magnesium, for example, more than 1 or more than 1.5. And our magnesium was 0.89.
Yes.
I thought that maybe that was some reason, for example, accelerated factor.
Yeah, definitely. That probably didn't help with her arrhythmia. One of the contributing factors. Yeah.
Yes, thanks.
Thanks. So she improved. She went to rehab on the 2nd of September. So that was after like over a month of her initial presentation. And she came back on the 6th of September with high CRP. And we thought, okay, the plan was for her left renal mass is to kind of get her a tiny bit better physically and then do the surgery elective. But she had high CRP and she went on with left nephrectomy. During the operation, intraoperative, her blood pressure surprisingly went up to 220, and she had a left radical nephrectomy, and also her left adrenal gland was removed. So her renal biopsy came back as a high grade rather than low grade, as was initially thought, cancer. And her adrenal gland showed some changes, the biopsy, but then that was discussed again and the biopsy was read again. And they thought, no, this is probably nothing, but she was screened for pheochromocytoma and there was no pheo. She was discharged to rehabilitation. And so this is just to mention that malignancy in Takotsubo cardiomyopathy registry was observed in 16.6 of malignancy was observed in 16.6 of cancer patients. I don't know why this slide popped in here, but anyway, and she was discharged. She was doing well. She was seeing urology in the meanwhile, and this is her ECG in May this year, so May 2020. So that was similar to the ECG before she had the very prolonged deep T-wave invasion.
So had her medicines changed substantially from the, pre-EKG to the ones with the prolonged QT to this EKG? Were her medicines different?
Not to my knowledge, no. So she was still on Tarceva, she was still on the cardiac medications. And this is her recent ECG from September. So QTC was good, changes resolved. And recently, she continued to have this regular cystoscopy, and they were monitoring her urinary bladder mucosa, and she had a biopsy recently that showed that she had carcinoma in situ, and she was started on intravesical BCG for that. With regard to her lung cancer, she became Tarceva resistant, and they repeated a biopsy test for the T790 mutation. She came back positive, and she was started on osimertinib. And we know that osimertinib is associated with, cardiac toxicity, including QT prolongation, heart failure, and arrhythmia, atrial fibrillation. So how often do you want to see this patient, and how often do you want to check her ejection fraction, and what's her risk of maybe we have to take Takotsubo recurrence out? So what's her risk of having similar, T-wave abnormality? And so Dan, do you go ahead with kind of a form of any electrophysiologic investigations or
what did you guys do last time with when she had her Torsad? What did you do?
When she had her Torsad, we gave her magnesium, and we thought, okay, she's unwell. Erlotinib is one of the also medication that you may blame by stretching, but not causing these abnormalities. And given that she got worse, and we talked about, okay, just leave her in peace and NFR, then she improved. We thought we didn't get a formal electrophysiologic study because for us, we didn't think about it. We didn't, we didn't think about it basically.
Yeah, I mean, I think at this point, the fact that she survived all this and is presumably walking around and otherwise doing okay, then it's hard to give up on her.
Yeah, she's doing great. In fact, she is doing great. She's a fighter, and her daughter is my patient also because she said to me, I would like to have investigation. So I get to see her and see her mom. They come on Saturday because they don't want to get exposed to other patients because of COVID-19. And she said to me that her mom really, she can't cope with her mom now. Her mom is faster than her walking, just to tell me that how much improved, over the last few months.
Yeah.
But how would you like to monitor her QTC?
Yeah, I think what we've done recently, because of the new technology with patch monitors, is that if she's going to start osimertinib, I would probably put a patch monitor on her for 30 days and see what happened. But I would also be very fastidious about making sure her potassium and magnesium were normal, and then I would eliminate any other medicines that are considered unnecessary.
Okay. And for her family history, given that there is a very strong family history of non-small cell lung cancer and non-smokers and Asian background, which is usually the case in this type of cancer. So I did refer her to a formal oncology genetic referral that she saw 2 weeks ago, and last week she had a panel of 28 genes sent. I didn't get the correspondence yet from that, but so just
for sending genetic tests, I mean, I probably would have sent an arrhythmia panel. We use a company called Invitae, and they have an arrhythmia panel which includes long QT syndromes. Yeah. So anyway, I don't know what company you're using for the cancer genetics, but certainly the cardiology based genetics, there's a panel for QT prolongation.
You will send in this patient a panel?
Yeah, definitely. Why not? I mean, she had massive QT prolongation and she had torsade.
Okay. And the torsade was in the setting of her being, unwell and temperature 41.
Yeah, but is she never going to have another fever in her life?
Yeah, she will. Yeah. Okay.
So I would say she's demonstrated her susceptibility to those problems.
Okay, so she will have a heart bug for a month, and we'll send a formal electrophysiology review for gene testing.
Yeah, like I said, we have, I'm pretty sure they're an international company, but the company that we use here for genetic testing and cardiac conditions is Invitae. There is Ambry Genetics, which is another option, but definitely Invitae has an arrhythmia panel. And if you already, if you had already sent blood testing for genetics, all they have to do is just retest the blood that they already have. So
okay, yeah. Yeah, and interesting, you're right, like 30% of patients with long QT, they have underlying, with a drug-induced long QT, they have underlying, genetic predisposition to that, some form of channelopathy. So there is no history of sudden death in the family or unexplained death.
Yeah, but she's.
But we'll get. Yeah.
In the end, if you summarized all the EKGs and slides that you presented, would you say would you say that you know exactly what happened with her?
No, definitely not. Because if we picked up a tiny bit of probably edema on MRI, would say, yeah, that was definitely for sure. Definitely, maybe, or potential high possibility, but no, we were not, because her MRI was normal, and her LV ejection fraction was normal at the time of presentation. But because of these type of ECG and the AVR, but you're right. So we'll get her monitored for with a heart bug for a month, get the gene testing and EP review, and also we'll get probably will be worth doing a 12-lead ECG for her children, for her 2 daughters and son.
If I could play devil's advocate here, if you were to get positive genetics, what are you going to do? Put in a defibrillator? Now, she had Takotsubo. Are you planning to keep her on a beta blocker? I mean, really, there's no good treatment, preventive treatment for Takotsubo, except a beta blocker, perhaps, which is more theoretical than proven. And
Yeah.
I'm not sure if her genetics are positive. You're not going to put a defibrillator in her. Certainly not, because of all the risk of infection and all the rest of it. And it is true, she had a torsade when she was presumably magnesium deficient and extremely high temperature. So it would seem to me that an approach would be to just monitor when you have her on new drugs, be sure her magnesium level is up, and then consider a beta blocker as a protection for a Takotsubo, and more or less leave it at that, but be very careful when you put her on new medications, and be sure her magnesium level and her potassium are good. In terms of diagnosis, it's beginning to look more and more like this was a undiagnosed Takotsubo, although I must say the QT interval prolongation is usually it's a little more precise, more like a sharper T-wave inversion, and almost more likely to be in the precordial leads rather than all the leads. But I don't see an alternative explanation for it, honestly. And I've never seen a Takotsubo without Takotsubo. In other words, without normal LV function. So that is surprising, although I have seen some patients, matter of fact, I'm following one now, a young girl, who has unexplained T-wave inversion that's persistent. That's all I have to say.
The thing with that, if she came back with a very convincing pathogenic long QT mutation, I think that will also make a difference for the rest of the family. Probably, as you said, it could be risky for, if she still have infection with an ICD. But for her, as it indicated, probably, yeah, you can argue that was in the setting of fever, and you can say, no, she already had one episode of, she already had a very long QT. And yeah, and given now the, the new oral, osimertinib that she's taking, probably, could be our way, put a defibrillator in or not. Will make a difference though for the rest of the family in terms of offering them gene testing. And if they test, for example, positive for her pathogenic gene mutation, and it was really pathogenic, then they will need to be kind of, monitored in the cardiology clinic.
Yeah, I mean, I don't have any disagreement per se with the discussion about ICD, but doing the genetic test is completely independent of any decision related to an ICD. In this lady with 3 or 4 cancers, depending on what you think, I mean, they did genetic testing looking for a genetic explanation for her cancers. And since it is available in this contemporary time for looking for mutations known to be associated with QT prolongation, I'm just saying I would do it because it's available now.
Yeah.
Now, I'm not saying it's going to change your management, but if she did come back with a significant mutation, you would certainly say, wow, I got to be really careful here.
Yeah.
So whether you put her on osimertinib or any other drug, you would still have to say, I have to be really careful here if she had a mutation. But if she had no mutation, then you might just say, and I don't know if you would say this, but you might say, okay, I'm going to chalk up her QT prolongation to the fact that, you know, maybe some electrolytes were off, maybe medications were a little bit funny. She got super sick, and, you know, all of that happened in the past, but it seems to be better now. And then I just leave it alone. So.
Okay. Yeah. Yeah, interesting. Yeah, especially with osimertinib, I guess. So she's coming for her, you know, the bladder cancer treatment. So I asked them to, she's coming for weekly. Every Sunday, so I asked to get an ECG just to see how is her ECG doing with the osimertinib. And if she's to develop similar QT, you know, prolongation and deep T wave inversion, do you go ahead and kind of, you know, discuss and suggest, you know, what to do with osimertinib, like if her QT stretches to 600 or more than 500 as the initial ECG that we saw?
Yeah, I mean, you'd have to wonder about that. But I think, you know, osimertinib is a better drug than erlotinib in terms of cancer. And so, you know, it's, her cancer is progressing. So,
yeah,
you know, I think it makes sense to go to that drug. I think you just have to watch her. But I mean, it's a super challenging case. I don't think there's a right answer.
Yeah, it is challenging. And if her follow-up ECGs show that her QT is stretching by 60 milliseconds or more, I think it will be challenging because in this case, probably we'll get the patient involved in the decision of what to do. Is that right?
Yeah.
Yeah.
All right. Well, we've this is a truly fascinating case, and thank you so much for sharing it.
Thank you.
You have, yeah, you have added a new little wrinkle to the whole picture. So.
Thank you very much. Thanks.
All right. Well, thank you all for joining. And Steve, what is our plan for next week?
Next week, we have at the same time a COVID-19 presentation by Diego Sadler. He was involved in a survey looking at the impact of COVID-19 on the cardio-oncology community.
Okay, fantastic. We look forward to that.
Thanks, everyone.
Thank you.
Thank you, everybody.
Thanks.
Thank you so much, Ruba.
Thank you. Thank you very much. Have a nice day.
Thank you.